After this very complex case, we are going to take you to a slightly different, world. Basically, as surgeons, we want to do new things, and when I took over as a unit head in 2012, we started the thoracic. We had a thoracic program, but we try to streamline it and try to introduce newer things like video assisted thoracoscopic surgeries, and then we get a lot of referrals from neurology. No, so just be careful now. Be careful when you send us the next time. So so then we moved on to other areas, and then what one thing we were lacking was the chest wall reconstructive surgery, congenital chest wall deformities, and part of the reason was that one is people are not very aware, and even if somebody has it, they kind of continue to ignore it, and we didn't have many solutions to that. But then the Nuss procedure started getting popularized in the world, and we also did 2 workshops where we got the people from UK and China who were doing it regularly. And then finally, Dr. Mohit took the lead and he went to Argentina for a 3 months fellowship. So today what we are going to talk to you about is our journey of how we started this and how we did our first procedure. And Dr. Pradyot will be presenting the case and then followed by discussion, and then Dr. Mohit will conclude.
Good afternoon, everyone. Our patient was a 14-year-old boy who was a resident of Uttar Pradesh, who was a student of class 9, who presented with complaints of depression of anterior aspect of chest wall associated with exercise intolerance for the past 3 years, which was progressively increasing. So he was apparently well 3 years back, but he was always aware of the chest wall deformity which he was having, which was gradually becoming more apparent with the passage of time. So he started having dyspnea on exertion 3 years back, particularly while playing, which limited his sports activities. There was no history suggestive of any growth abnormalities. He also achieved normal milestones. There was no history of any respiratory or cardiovascular disorders. He did never have any joint dislocations, frequent sprains, or hyperextensible joints. There was no history of any trauma to chest wall, no prior surgeries also. There was no chest wall deformity in any family members. So he had visited multiple facilities where he was worked up with chest x-rays, ECGs, echo scans, pulmonary function tests, CT scans, and a lot of other investigations, which eventually turned out to be normal. And subsequently, he was suspected to a psychiatric evaluation, which was also normal. And ultimately, his symptoms were dismissed, and his parents and he was reassured. So deeply troubled by his persistent symptoms, he presented to AIIMS. On presentation, he was bothered by his deformity and exercise intolerance. He did not have any other significant complaints. On general physical examination, he was conscious, cooperative, well-oriented to time, person, place, and he was thin-built, and vitals were within normal limits. On respiratory system examination, he had a pectus excavatum which was asymmetrical, with a plateau deformity with subtle costal flaring with no associated spinal deformities. And auscultatory findings were also unremarkable. So this is the image of his chest wall during presentation. Other system examinations were also unremarkable. So we started investigating this patient with radiological imagings, which would be discussed by Dr. Salai from the Department of Radiology.
Good afternoon, everyone. I will be discussing the radiology of this patient. Coming to the chest X-ray, in this only abnormality we can appreciate is here the posterior border of the ribs are more horizontal. However, when we trace the ribs more anteriorly, it is more oblique in nature, giving the 7 sign, which is one of the indirect indicator of pectum excavatum deformity. This is This is the representative image where we try to trace the posterior rib, which gives more like a 7-like appearance, which is one of the indicator of pectum excavatum deformity. Other than this, no significant findings in chest X-ray. Bilateral lung fields are clear. There was no evidence of any scoliotic deformity. Next, a patient was also underwent a NCCT chest scan, where we measured the Haller index. Haller index is one of the traditional index which we use to measure the severity of the pectum excavatum deformity, where we divide the maximum transverse diameter of the thoracic cavity by the shortest AP diameter at the level of the maximum sternal depression. When we measure the values of this patient, it comes around 3.9, which fits into severe excavatum deformity. Next, we calculated the pectus correction index, which is one of the novel index to calculate the severity of the pectus deformity. In this, we basically take a reference line at the anterior border of the vertebral column, and with the line as the baseline, we take two measurement. One is the maximum anteroposterior diameter of the chest wall, and another is the shortest anteroposterior diameter of the chest wall at the level of sternal depression. When we divide the maximum normal anteroposterior diameter from the minimum distance, we get the pectus correction index, which came around to be around 17.4% in this patient. More than 10% is diagnostic of pectum excavatum. Higher the value, more severe the deformity. Most of the surgical candidates fits within the value of 20 to 40%. Also, the pectum excavatum pectus correction index of more than 28% correlate with Haller's index of approximately 3.2. Coming to the another novel index called Titanic index. Titanic index is basically the percentage of sternal depression. In this VRT image, we basically took a 3 point as reference. One at the upper border of the manubrium sternum, and point B, which is the point where the sternum dips behind the pectoral ridge. And point C is the lowermost point of the CP sternum. When we divide the maximum and craniocaudal distance of the sternum by the length of the sternum, which is dipping behind the pectoral ridge, which is BC, it comes around 34.8%, which is the percentage of sternal depression in this patient. One of the study by Belia Munzon states that if the patient has a Titanic index of more than 66.5%, we might require more than 2 bars for the surgical fixation. Our patient had a Titanic index of around 34.8%. We also done a cardiac MRI for this patient. In this, we can see there is the right ventricular compression. This is the right ventricular cavity. This is the sternum. We can see there is a right sternal torsion and also mild compression of the right ventricular cavity by the sternum. This is according to Obermeyer classification. This is type 1 compression with right sternal torsion. Also, there is another subclassification for the right ventricular compression by Devigiano. According to this classification, this patient have class 2 right heart compression, which is mid right ventricular compression.
Thank you. So the radiology gave an idea about our diagnosis. So to complete our investigations, we did an echocardiography, which turned out to be normal, and also a PFT and a 6-minute walk test were also done, which were also subsequently normal. His hematological and biochemical parameters were also within normal limits. And from the clinical examination findings and the investigation which we had done, a diagnosis of pectus excavatum, asymmetric plateau type with subtle costal flaring without any banana sternum or spinal deformity was established. And a plan was made of Nuss procedure with 3 bars, one in each third, fourth, and fifth intercostal space in an uncrossed fashion was planned. Now coming to surgery, the patient was placed in supine position with sandbag placed between the shoulders of the patient to make the chest wall prominent. Markings were done of the intercostal space and also of the entry and exit sites of the Nuss bars over the chest wall. The bars were contoured and molded on table. So the chest wall is lifted up using a chest wall elevator. So during this time, we didn't have dedicated instruments or equipments for this procedure. So we basically set a jugaad using a towel clip, which was coupled with a rib approximator, which was further attached to a Thomson bar. So you can see a thoracoscope being inserted through the seventh intercostal space, and incisions were made in the second and fourth intercostal space, centering the anterior axillary line on both the sides to facilitate the entry of Nuss bar. So this is the jugaad which we made of the towel clip and the approximator. So this surgical video shows retrosternal dissection in the loose areolar tissue. So using a pectus introducer, we introduced an umbilical tape which was traversed across the chest wall, which guided the entry of the Nuss bar into the thoracic cavity and from there outside. So you can see the Nuss bar being inserted, and everything was done under thoracoscopic guidance. Now the Nuss bar has come inside, and we are guiding the bar under thoracoscopic guidance to prevent injury to any thoracic viscera, that is the bilateral lungs and the underlying heart and pericardium. And it's also facilitate the exit of the Nuss bar through the desired point to provide a perfect desired outcome. So the bar has now crossed to the opposite side. So once the bar completely crosses to the opposite side, the bar is now flipped, which pushes the chest wall outwards, which instantly provides a correction to the deformity. So this is a post-op image of the patient. Here you can see that an instant correction of deformity is achieved. So this is the immediate post-op X-ray, where you can see the Nuss bars which are placed, which are stabilized by the stabilizer, and the deformity has been also corrected. So after 1 year, the patient is now asymptomatic. He is very happy with his appearance, and he is also very confident. He has no shortness of breath. He is currently continuing his school education and has passed his 10th board exams in flying colors. So after 1 year, this is the current condition of his chest wall. There is no significant residual deformity, and also he has not had any relapse of his deformity, and there is also minimal surgical scar. And this is his X-ray after 1 year of surgery, where you can see the bars are still in place, not displaced, and the correction is also stable. So he is planned for implant removal after 1.5 years from this time. So now I invite Dr. Rahul for further discussion on this topic. Yes, sir. His exercise and intolerance have significantly improved. He is now able to, progressively improved, and he is currently able to do normal activities without any complaints. Sir, previously also we didn't have any significant changes in the pulmonary function test also. Excuse me, sir. It was almost okay. So basically everything was because of the chest wall compressing his lung. Yes. Up to Dr. Rahul.
Thank you, Dr. Pradyut. I will cover the discussion part, which includes the overview of chest wall deformity, understanding of the pectus and the incidence, and workup of the pectus excavatum and its management part. So, chest wall deformity is broadly classified into the without aplasia and dysplasia, which is most common type, which includes the pectus excavatum. It corresponds to about the 88% of the total deformity, followed by the chest wall protrusion, which and other two rare variants include the pectus arcuatum and the mixed type of variant. When it is associated with the aplasia and dysplasia, this is less common and presented with a complex form of the chest wall deformity. So this is an image of the pectus excavatum, followed by another image in the pectus carinatum. In both sternum as well as the costal corner cartilage are protruded outside. This is a mixed type of pectus excavatum in which one part is depressed, whereas the other part is protruded outside the cavity, outside the thoracic cavity. So in another rarest variant is a pectus arcuatum, in which upper part of the manubrium or upper part of the chest is protruded outside, whereas the middle or lower part of the chest is depressed inside the cavity. So I will focus my talk on the pectus excavatum, which is the most common congenital chest wall deformity. And it is seen that incidence is 1 in 300 to 1000 live births, and which the male predominant. And when we review the incidence and prevalence to see the prevalence of the pectus excavatum, it is we found there is limited data from the Asian country, whereas the most of data is from the Western country. So up to date, only 2 paper has been published from the Asia, one to see the incidence and prevalence of the pectus excavatum in the children age going. And there is no study from the India to see the incidence and prevalence, though we are conducting a study to see the prevalence of the disease in the northern part of the India. So there are various symptoms questionnaire is available to see the severity of the pectus excavatum, which are available for adults as well as the children. But most of these questionnaire focus only 2 things. One is the cardiorespiratory symptoms, another is a psychological symptoms. In cardiorespiratory symptoms, most common is a exercise intolerance, followed by the chest pain and exertional dyspnea. Whereas the issue related with the body image we cannot ignore, because there are many literature which show that these patients have a low social withdrawal and a suicidal tendency and low HRQL as compared to the normal population. So coming to the workup of the pectus excavatum, the history taking, which includes the onset, duration and progression, because it will guide whether the disease is stable or it is in worsening condition. And family history should always taken because it is seen that up to the 40% of the patient have a family history, but there is no gene identified till now. And history of the previous chest wall or thoracic surgery, because it will guide the further surgery difficult. So the deformity may be symmetry or asymmetry, which are best visualized in the oblique and lateral view, whereas the either oblique and lateral view followed by the superior view. So there is another based on the morphology, there are another deformity which may be localized in the image. There middle and lower part of the sternum is depressed inside, and the deformity is localized here. In another diffuse type of pectus excavatum, the area of defect is broad and it is shallow, whereas in long type, there is a deformity is elongated along the sternum and it is a deep as compared to the diffuse type. So investigation include the NCCT chest, cardiac MRI and 3D scans. But another investigation also include the stress echocardiography, 6-minute walk test and a pulmonary function test. And as explained earlier, there are a CT scan is used mainly for the to define the indices, various indices of the pectus excavatum, as well as the other bony deformity like the chest wall tumors and the scoliosis. So stress echo, it also denotes the severity of the pectus excavatum, because it may compress the cardiac chamber and there may be rotation, which leads to the right ventricular outflow obstruction and right ventricle decreased systolic right ventricular function, as well as the right axis deviation and the ST depression. So most of the patient presented as a normal PFT, and these PFT do not correlate with the objective value of PFT, because PFT are doing in the resting stage, whereas the most of the patient complain of the exercise intolerance, and it may be used as a follow-up tool in a patient where the PFT is affected. So for further discussion, I will ask Dr. Mohammed to continue.
Thank you, Rahul. And I'll be discussing the management part of pectus excavatum. So surgery has already been described. So there are 2 approaches. First is open and second is a minimal invasive surgery. The question remains that can these patients be approached through vacuum bell therapy, non-operative management? And vacuum bell therapy is one of the answers to these questions, that these patients can be managed with vacuum bell. Although the concept is relatively new and its gain in acceptance in early 2000, the data is limited, but the literature is improving over the past 10 years. So what is the biomechanics of this vacuum bell? So whenever we apply the vacuum bell over the chest, it will create the negative pressure and it will immediately lift the chest wall as a depressed part of sternum and costal cartilage. And whenever it is applied for a prolonged period of time, it will remodel the entire chest wall. So these are the various sizes and configuration of vacuum bell, which is necessary to choose for each patient, specifically for adolescent girls, to achieve the optimum outcome. This is a small clip which is showing that the vacuum bell is being applied. Now the negative suction is being created. you can see that the chest wall was depressed, but when the negative suction was created, now it is lifted up. So the best candidate for vacuum bell therapy will be a young patient with pliable chest wall. And if patient of any age is not willing for surgery or denying for surgery, these patients can be offered vacuum bell therapy, but these patients should be explained that outcomes are based on compliance and not universal in this age group because of the rigid chest walls. Surgery will be offered to the patients who are symptomatic, as been discussed, and who are suffering from moderate to severe deformity, as depicted by the CT indices. Social or psychological problems may alone be an indication of surgery, and in cases of failure of vacuum bell therapy, the balance shift towards the surgery. So whatever the approach may be, but the entire principle of surgery remains the same, that thoracic remodeling, it can be achieved through resection of resection of costal cartilages or the remodeling the sternum, or maybe it can approach through non-resectional methods. Classically, in 1949, Revich described the open procedure where resection of costal cartilage and substernal osteotomy was done. This was a landmark procedure and it went for a longer period of time. But this operation had a price to pay, that this operation was very invasive. It required larger incisions, as you can see here. It was performed in the younger children, so it disturbed the growth impairment. It was associated with poor cosmesis, as you can see here. And in extreme cases, it can lead to acquired Ewing syndrome. For decades, surgeons went on and performed these radical surgeries, and where they removed the costal cartilages and remodeled the sternum by doing the substernal osteotomy. So after observing these, Donald Nuss asked a simple question, that if child's chest is so much flexible, why do we need to resect it? Why not just reshape it? So based on this principle, the entire treatment approach and philosophy of the pectus cavatum treatment changed. He started his surgery in 1987, and after the patient work of 10 years, he published a paper in 1998. The procedure include keeping a small lateral incision over the lateral part of chest wall, creating a substernal tunnel, and through this tunnel, as we already saw, that bar is passed, and once the bar is in place, it is rotated to 180 degree to elevate the sternum. And more importantly, this procedure does not involve resection of cartilage or does not cause any sternal osteotomy. And whatever the bar we have kept behind the sternum, it can act as a temporary internal brace which can be removed later on. So this is a small graphical representation which we have already shown in the video, and we have discussed that bar has been inserted, it has been in place, and then the flip is done. So these are the advantages. Without resection or osteotomy, the instant elevation is achieved. So when Nuss introduced its procedure, as similar to other scientific innovations, it was not initially embraced well, but slowly the results were dramatic and outcomes are excellent. So it has become a standard of care in many countries since last over 2 decades. The advantages are quite clear. It is a minimally invasive, it preserves the growth centers, it provides better cosmesis. Within the short recovery of time, patients can be discharged earlier, and without any resection, this procedure provides natural chest wall remodeling. Original Nuss, which was described in 1998, had some limitations, such as there was an insertion of bar without any vision, so there was blind entry. There were issues with bar displacement and removal of the bar. There were issues with pain and inadequate support to the rigid chest wall. And in complex cases, such as in adults or redo cases, it was difficult to perform. So one of the modern modifications came when thoracoscopy came in the picture. So it basically converts a blind maneuver into under direct vision, where you introduce the bar under vision and the chances of injury are reduced. Second modification, specifically in the cases of deep deformities where the working plane between the sternum and the heart or pericardium is very less. In these cases, you require a working plane. So to achieve that, you apply a crane as a sternal lifter, and through that, through this video, we can understand that there is a crane which has been applied. You can see the chest wall is being elevated. And now we are having some space between the pericardium and the posterior wall of sternum. So through this, injuries were reduced. In the initial procedures, the stabilizers were used and they were associated with complications such as bar displacement, rotation or migration. And these complications were tackled with introduction of bridges. And our ultimate goal for the pectus deformities are to achieve the total thoracic remodeling. So in patients of severe deformity, in recurrent or redo cases, patients who have rigid adult chest wall, various configurations such as multiple bars, parallel bars, or crossbar used, as you can see in the chest X-ray images. So the surgery of pectus excavatum has tremendously improved from initially putting a larger incision to now introducing multiple small incision. From a now we are doing the minimal invasive surgeries also. And rather than offering patients a single radical surgery, we are offering patients a customizable platform to each patient differently. Now I would like to invite Professor Mohit to give his, to narrate his journey of pectus.
Thank you, Mohammed. So our journey has been very interesting. It has been very long also. Long not in terms of the timeline, but long in terms of the place where I went to get trained. So it was a very long, arduous journey. But why we went so far was that the pectus deformities, they're relatively uncommon in our country. The Nuss procedure, they're performed only by a handful of surgeons, and that too sporadically. There is no high volume center in our country, and there are limited opportunities for training. Now, why I selected this center was that there is like one of the center with very high volume. It's very renowned. Not only they have devised new techniques and equipment for Nuss procedure, they are very much into the research activities too. That's why I selected this center. So this is the team and this is the hospital where I got trained. And after having getting some exhaustive training of last kind of 3 months, we came back and started the work here. So what we achieved in less than 2 years or so, that now we have a dedicated clinic on chest wall and pectus deformities on every Friday from 2 to 4 in room number 1. And I request all of you that if you find any suitable patients, please guide those patients to our clinic. We are seeing all sort of see patients here. So if you see the world literature, they say that the pectus deformities, they are less common in developing countries. No, we see a lot many patients. So you can see all varieties of pectus excavatum, carinatum, arcuatum, and not only these kind of conventional patients, we have some difficult patients like this. So you can see the patient on the right side, very deep pectus. The patient with recurrence who had underwent surgery by open technique in the childhood. Then we have patients who had underwent thoracotomy and they present with pectus. So we have all complex patients as well. So in this clinic till now, we have registered 82 patients. We have done surgery on 11 patients, including 6 Nuss procedures. Recently, we did one interesting case where this young girl was having a mitral valve prolapse, and that was to be replaced, and she had pectus excavatum as well. So we performed this in a single sitting along with the CTVS team. So you can see the mitral valves were replaced, and the bars were also put in the single stage. So this is how she looked preoperatively, and this is after surgery. So the correction was performed, and the open heart surgery was also done. Apart from this clinical work, we are involved in the research work as well. So till now we have this study and the results, they are very interesting. Again, you see that world population says that excavatum is more important, is more common. But here we have found that in our patients, carinatum is more commoner than the excavatum. Now these are interim results, but still it shows very significant findings. And interestingly, the number of females, they are relatively more as compared to males as we compare this with the world literature. Initially, when we started the procedure, it was a headache because the implants were not available. Only one company was dealing with it, so it was difficult to get. The bars were very costly, and the procedure obviously is not covered under government health schemes. So somehow we got access to an Indian manufacturer, and then he obliged us by developing and modifying these bars. So now we have some cost-effective implants, and as like Dr. Pradyut it said earlier that initially we had that kind of jugaad, but now we have a dedicated chest wall elevator for this. So this is how it works, that it elevates the chest, which is required during this procedure. Not only this, we have modified our equipment as well. So initially we used to have these ragged kind of edges in the bar, which makes it difficult to kind of insert and take it out. So now we have converted into smooth bars. We have shifted from the stabilizers to bridges. So all this in last 1.5 years or so. We organized last year an international conference on chest wall deformities. And not only in the institute, we also conducted some workshop elsewhere. So this was last year in ISTS Con in Jodhpur. But this is again a small journey. So we have miles to go. We have to increase the awareness of this particular deformity in the public by lectures, by community work. We definitely have to expand the training and the learning activities, and we have to augment the research activities. With this, I acknowledge my mentors at Clinica My Pectus, Argentina, the patients of chest wall deformity, our implant manufacturer, the departments of pediatric surgery, orthopedics, and CTVs who guide patients to our clinic, the departments of radiodiagnosis and anesthesia who help in managing in these patients. And I also kind of thank Dr. Rajinder Prasad, who kind of, he taught us the nuances of thoracic surgery, and also he's nurturing our interests. Thank you, sir, and thank you all. I open this session for questions. We got so many patients from you, Dr. Vishesh. Right. Right. So, right. So we molded the bar before surgery. And then when the sternotomy was performed, the CTVS guys, they did the component. Then we just approximated it. We did the sternal closure and then put in the bars. So it was almost like in any naive patient, except that there was sternotomy. This has been done elsewhere also. Yes. Yes, yes, absolutely. Right, 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 right. Yes, 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 yes. Right, 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 right. Perfect. So I really appreciate your questions. So there are too many questions. I'll try to answer them one by one. But I really appreciate these questions because they are the real problem. The first thing about pain you said. Yes, pain. This is one of the most painful surgery. So we don't have cryoanalgesia as of now. So elsewhere, cryoanalgesia is the standard of care, but it's not in every country. So like Europeans, they still go for thoracic epidural and they will give local blocks. So we are using thoracic epidural block with IV analgesia and followed by oral analgesia. So somehow our patients, they're not doing that bad. They're doing good. But then definitely we have experienced that they have pain in the initial postoperative period. We are migrating to get the cryoanalgesia. In the last patient, we could perform cryoanalgesia. It was not thoracic cryoanalgesia. It was performed from outside, percutaneous one. So it was not an intraoperative one, but we have started doing it. The second question was about bar migration. Yes, definitely. Initially, when we used to put, elsewhere, when we used to put like one bar with one stabilizer, there are chances of migration of the bar. With the development of bridges, it forms kind of a block where it doesn't allow the bars to kind of move in any direction. So the first patient which we presented here, we used stabilizer. But after that, we asked our implant manufacturer to give us, the bridges, and now we are using bridges. So I did one last patient of Nuss yesterday, and we use bridges in that. The third question was about multiple bars. Yes, but then again, we have to tailor the requirement of the patient and match it with what he requires. So if the depression is diffuse, means the one which he did was a plateau kind of deformity. So plateau is a long one. So 2 bars won't work in that. You have to have 3 bars. If you have more of rigid chest wall, if you are using 2 bars, then there'll be more pressure on the wall and on the bars or on the intercostal spaces, and the intercostal muscles, they may simply strip. So a 3rd bar is added so that the pressure of the chest is kind of distributed and there is not much pressure on the bars. So how many bars, how to put in what configuration depends on the presentation of the patient. The morphology of the chest may not objectively on the parameters of CT scan. A recurrence was the answer. It's a recurrence, like again, If we use multiple bars, if we use some hammock suturing kind of thing, and we're using bridges, the recurrence is less. We have just started. We have to yet see that whether our patient they recur or not. Sir. Yes, sir. Yes, sir. So, yes, sir. The time period is 2 to 3 years. So usually at 3 years of implant, the chest wall is remodeled and we remove the bars. We have yet to remove the bar, ma'am, because our right. So the bars they rest on the chest walls. So the outside of the ribs, they provide. Yes, not to the ribs, to each other. To each other. Like if you have having 2 or 3 bars, they are fixed to each other. They still rest on the chest wall in the intercostal spaces.
So with that, I would like to thank you. And this is an interesting topic. We can have some questions over the cup of tea.